Thanks, everybody. And I really hope everybody has had a wonderful conference. Thank you. Libby, if you stop sharing that, we'll
Yes.
see. Hopefully I can share, and that way I can kind of see who's here. Um, so let me tell you about my goal here. My goal is to kind of um, check in with everybody here and people's thoughts about where peer services are in California, where we want to go, and to follow up in this conversation with a forum co-hosted by CAMHPRO and SHARE that helps us come together as peer support specialists, peer-run organizations, people interested in quality behavioral health services to help develop a roadmap of and an understanding of where we are and where we want to go. So to start this, I'm just going to really briefly, I put some slides together. They're sketches. They're to develop conversation. This is not in depth, but I wanted to share. And then I'm also going to share, I'm going to upload, I'll do this now, and I'm going to do it later as well, but I'll put into the chat, there is a document here, I think.
Is it a form?
It is a Word document. So hold on. It's going to take me a second to find it. But this document, let me just, here we go. Okay. All right. So this is a version of a document called Scaling Peer Services in California. This was created by Sally Zinman, the founder and former executive director of CAMHPRO, or one of the founders, and myself. And it was created because Stephanie Welch, who's the deputy director of California Health and Human Services and the behavioral health side, asked us what scaling peer services in California would look like. And so this is for you to read and develop. And we tried to talk about the importance of developing a robust system through MHSA to scale things like peer recovery centers, peer respites, crisis peer respites, forensic peer services, for crisis response for peer services, and peer-run housing. And so this is an overview, but the state has this. And then to kind of kick us off here, I'm just going to talk about kind of how things have developed a little bit, and where we stand in California. This is a really critical time. We've got SB 803, so there's a certification process for peer specialists in California that includes specializations for forensic peer services in housing and homelessness, crisis peer services, and parent, caregiver, and family peer services as well. The question is, how do we really scale these services in California in a way that gets California to a place where peer services and efficacious or peer services that are aligned with the values and practices of peer services are a robust part of everything that California is doing to address its pressing issues. So as an overview, right now, the state funds peer services primarily through two components. And I'm talking about the state. Peer-run organizations can get other funding and will get funding from, at times, sometimes they get corporate donations, sometimes they get grants from foundations, and they get individual contributions. The state looks like it's funding peer services primarily through MHSA and Medi-Cal. And there are issues with both. So MHS and in terms of the state agencies that could fund peer services, there's DHCS, which is the statewide health agency. There's HHS, which is Health and Human Services. SAPC is Substance Abuse Prevention and Control. And then there's county departments of mental health. And on the corrections side for forensic peer services, I don't know what agencies are there, but there's that. There's also Department of Public Social Services. So those are agencies, statewide agencies, that we can think about as how, as peer services become more robust and we develop this workforce, how can we advocate at those agencies for those agencies to include peer services in what they're doing and what they fund? Those agencies also often contract through contracted, they put requests for proposals out so that community-based organizations get contracts. And for example, that's how SHARE has many of its contracts, is through county agencies that are sometimes funded federally and sometimes by state agencies. When we look at MHSA, currently, MHSA has funded client-run centers, wellness centers, peer respites, and those are to varying degrees in how they're practiced, done by peer-run organizations. In Los Angeles County, there are client-run centers that are not done by peer-run organizations, but those are funding mechanisms that MHSA has for funding peer services. There in Los Angeles County has 2 peer-run respites that are funded under MHSA. And I put full service partnerships here because even though they're not a peer-run kind of program, full service partnership teams often have peer specialists as part of the team. And the state sees, a large amount of how it uses MHSA funding is going to full service partnerships. So if we look at full service partnerships, how can those be more, how can they be re-envisioned in some ways to maximize the benefit of peer services? There's a threat here with MHSA in that Prop 1 is likely to divert 30% of MHSA funding to housing, directly to housing. And traditionally, the way that funding has been used, it's been used to do capital development. So that's funding to build new projects, and those buildings are often used for project-based housing. So it's, matching a physical location with a voucher and then a person to that voucher to stay in that. And that kind of housing is very expensive. In California, it's conservatively $500,000 to $700,000 for one unit to house one person in that kind of building. So an additional way that the Prop 1 is looking at funding MHSA is dedicating funds to full service partnerships. So there's a potential there for us to advocate for how we get full service partnerships maximizing peer services and peer support. So one question here is, can the state scale peer respites and peer run housing under MHSA housing. So for example, LA County, in its MHSA planning that kind of just wrapped up, its proposal for MHSA moving forward is that the LA County Department of Mental Health wants to do at least 6 more peer respites in LA County, using the kind of template that they put out before, hopefully under innovations. That would mean 1 peer respite in all 8 of the county's regional and kind of service planning areas. And the way that LA County is looking to fund those is using peer respites as housing through and using the MHSA housing dollars, because LA County is trying to plan as if Prop 1 is going to pass. So an additional question there is how we get more robust peer-run housing to be part of the housing component that MHSA funds. And I'm throwing a lot out at you, I know. So on the Medi-Cal and Cal-AIM side, there's, and this is where SB 803 was specifically developed to scale the workforce of peer specialists that are certified to bill Medi-Cal. So I saw you had a question, John. I just don't want to miss you. Oh no, it's Donza. Go ahead.
I'm just trying to be clear. You said MHSA, the acronym stands for what now?
That's the Mental Health Services Act.
Okay, now, and you said Prop 1 is some measure that's on the ballot, or is they're trying to get it on the ballot?
It's on the ballot. It's on the ballot from March 1st, and voters are going to see Prop 1. The way it's going to be written is this is money for mental health and housing. So Californians are likely to go, oh, yay, we want this.
Okay.
What's not going to be on the ballot is that it's taking money from MHSA, realigning MHSA to do the kind of housing that is really expensive, takes a long time to develop, and people often experience as prison.
And a lot of people aren't going to be able to afford the housing anyway.
Right.
So, okay. So when I see that on the ballot, just vote no or don't vote at all on it, right?
There is I'm not a lobbyist, and I can't give that. I will say that there's a group of people called No on Prop 1 that they have a website. You can go and you can look at all those arguments, and they're not funded nearly as much as the governor's office to support which supports Prop 1. It's the governor's proposition. So good question, and thank you. And so, but let me talk about that really quickly, because the Mental Health Services Act, Prop 63, specifically allocated dollars, I'm going to go back here, for mental health services that were not funded in other ways. So it was specifically for services that were not able to be billed to Medi-Cal, which is the main funding mechanism for services in California. And it was things that are not a medical model. So MHSA was specifically supposed to be, had an anti-stigma prong, was recovery oriented, had peer services, community-based services, and culturally and linguistically appropriate services for underrepresented communities. And this ballot measure, Prop 1, changes that. And the governor is trying to get MHSA dollars to be a dollar for dollar match with Medi-Cal. So every MHSA dollar is tied to a Medi-Cal dollar so that the state can get reimbursed, because the state is in a budget shortfall and needs to maximize the amount of funding from the federal government that it gets. So it's really important to understand MHSA as a mechanism for non-clinical, non-medical model services. And that's under threat. So having said that, Medi-Cal and CalAIM does try to update Medi-Cal billing procedures and programs so that they're more community-based, and there's kind of alignment in health, substance use, and mental health services, that people aren't siloed as much and that people can be served more easily in community. Primarily, Medi-Cal is used with directly operated agencies. So county departments of mental health on the mental health side of things are most of what they're doing is billing Medi-Cal. Some community-based organizations are able to bill Medi-Cal. They're site certified to bill Medi-Cal. Very few community-based peer-run organizations are site certified to bill Medi-Cal. And with the passage of SB 803 and scaling a peer workforce that emphasizes peer support specialists who are billing Medi-Cal, right now, the only places that are billing Medi-Cal are directly operated agencies. So we're building a workforce that is coming into a model that's based on clinical and medical model services, and integrating that with peers that are billing Medi-Cal to do peer services. And while that may be important, there's no ability to right now to scale community-based organizations that are able to bill Medi-Cal, because to qualify to bill Medi-Cal as a site, organizations, companies, agencies have to do two things. They first have to have an existing contract with a county to be eligible to do the second thing, which is to become site certified to bill Medi-Cal. And counties have not been doing new contracts with community-based organizations so that they can be eligible to be site certified to then hire all these peer specialists that can bill Medi-Cal. So if that's going to be a way to scale peer services, it's important to make sure that every county is contracting with community-based peer-run organizations so that those organizations can be providing peer services under Medi-Cal. So, Donza, did you have another question?
Yeah, just to be clear, I'm under the impression that it sounds, what I'm gathering is, it seems like they're trying to make peers, prevent peer support people with peer support specialist training experience not be able to enter the workforce for fear of job security for people who have degrees who are already in the field, and at the same time not be able to hoard the funding that would be paid out to peer support workers. That's kind of what I'm getting out of everything you're saying.
Well, I think I can't necessarily speak to the motivation. I can speak to how the planning happened, because the state did try and get some input, and these concerns were raised. So Medi-Cal is only one way of billing peer services. Counties in California weren't particularly aligned to peer services and peer practices before SB 803, did not scale MHSA peer services. And the reason they didn't scale MHSA peer services was because the thing that happened with MHSA was that it came online right at the beginning of California's last major recession. So all of the counties that had MHSA dollars were losing the dollars that come through new vehicle taxes and things like that. Their community support services dollars were going away because there was a huge recession. And what they did, and Michelle Cabrera, who is the executive director of the California Behavioral Health Directors Association, testified that when MHSA was rolled out, it was used as a safety net for existing services rather than being fully implemented as doing new services like recovery-oriented services and peer services. So that's still where we are. And because of that, we didn't get a lot of peer-run organizations getting contracts with counties under MHSA. So that as SB 803 rolled out, the only places that were ready to immediately bill Medi-Cal for peer services were agencies that were already billing Medi-Cal. And that's all the directly operated clinics. So those are the places that now have the capacity and the ability to reimburse the staffing cost of a Medi-Cal peer specialist because they can bill Medi-Cal. They can employ the person, boom, they're doing services and they can bill Medi-Cal. For a community-based organization to build Medi-Cal, it's going to take a lot longer. And the planning process for SB 803 implementation didn't include this other process of, hey, how are we going to develop capacity in community-based organizations to be able to qualify to bill Medi-Cal for their staff? So that's something that we need to look at. And that's kind of covered here. So having said that, Medi-Cal billing does currently require medical necessity. So some questions that come up with that as we look at this are, what are the ways that we can ensure the efficacy of peer services under Medi-Cal billing? And what are appropriate settings for peer services under Medi-Cal billing? Or what kind of relationships are going to lend themselves best to matching the efficacy of the peer service and billing under Medi-Cal? There's different ways to do it. For example, at SHARE, even though we're not billing Medi-Cal now, we do have some contracts where we have to do case notes. And instead of having the peer specialist do the case note, we have a transcriber do the case note so that the peer specialist can focus on the relationship, spend most of their time in the relationship and in the peer language rather than the case note language. So let's talk about certification. So one of the issues here with certification and training is that and I think we've covered in this conference, I think it's come up in a couple of presentations that I was in, the topic of peer drift, where the role of the peer support specialist is moving away from the evidence-based practice of peer support or the values of peer support. The way that California developed its certification criteria and its exam was skewed by peer drift because there was a landscape analysis of peer support specialists working in California that was used to develop the exam questions. And most peer specialists in California are still employed on teams that are not supervised by people with lived experience that are trained in peer services, that are multidisciplinary teams, that are in clinical settings or medical settings. So when they were asked about their role, they were responding with their role, and their role is already problematic because they're being pulled away from doing peer support in their role because they're in a different setting. So as we move forward with both certification and training, one of the things that's important is how do we guard against peer drift? How do we maximize the stakeholder process? CalMESA or MHSA is the certification body for peer specialists right now. They had some stakeholder input in the development. How do we make that stakeholder input more robust? How can it, there are probably a dozen-ish training vendors that are doing trainings in California. How do those training vendors provide input on what they're seeing in the process? How do we have transparency for how many people are passing, how many people are not passing? Is there a measure that helps us ensure that we're developing competency, not just training people in the information that they need to pass the exam? And another issue is the competencies themselves. So the 17 core competencies are general competencies. They are not, except for one, which is peer listening and disclosing, they are not specific to the practices of peer support. So when you look at something like linkages to services, every behavioral health career provides linkages to services. Housing navigators, case managers, social workers, nurses, all of them are providing linkages. So how do we get to the common competencies that elevate peer practices and have a standard for that, for how people are trained and how people demonstrate competency in the practice for all of those core competencies? So, I'm sorry. And the specializations are going to be rolling out as well. So forensic peer services, crisis response, peer services for people experiencing homelessness, and then parent, caregiver, and family specialization. And training, some of the things that have come up in training is how, I've talked about this just a little while ago, how do we make sure that the training develops competency in practice? How can we measure that as certified peer specialists are, move through the training, certification, and hiring process and get into the workforce? How do we elevate competency in the practice? Another thing is, when this was rolled out, there were scholarships for people to take the training and the certification. Those scholarships in many cases are expiring. So what's a funding mechanism moving forward for people to have access to the trainings and to the certification process? And then how do we measure success of the trainings? And as we talk about the workforce, how do we have a workforce with transparency and safeguards for pay equity and career development, so that once somebody is a peer specialist, is there a mechanism for them to be a supervisor, a manager, a director of services? What does that look like, and how do we develop that? So I wanted to just kind of start with that, open it up to questions and comments, and then please also, when you if you have a question or a comment, please put it in the chat so that we can capture it, because I want to use this as a starting point to move forward and really create something that we can strengthen our relationships with each other and with others in the state, so that we're creating scalability for peer services in California. All right, I'm going to shut up now.
Wow, that's a tough act to follow, Jason. So Jason has laid some science on you. He's given you some legislative things to talk about. There's the big Prop 1 that's happening this spring. And the overarching question for us is, how do we, as a group, as a community, how do we advocate for ourselves to strengthen funding mechanisms, to seek out more opportunities, maybe in areas where there isn't currently a lot of funding, how do we fill in some of these gaps? Anyone have any thoughts about this? Or in general, comments about things that you've learned about today?
Yeah, I wanted to ask if he could elaborate again on something. I think I heard him say something about the way the tests were set up for the test taking mechanism or tools, or the way the questions are geared for the peer support specialist. I didn't catch everything he said about that.
So I will, and this is good timing because I am newly certified. I took my exam and I passed. Hooray. So I'm a certified peer specialist in California. I've been doing peer support work for 20 years and I'm certified. And that 2-hour exam was a lot of it was clinical language. A lot of it was clinical practices. A lot of it was not recovery-based language, was not peer-based language. And that's because it was developed through an analysis of what peer specialists are currently doing in California. And currently in California, peer specialists are often doing things other than peer services because of peer drift, because they're asked to make sure somebody takes their medication. They're asked to drive somebody somewhere. And those kinds of things that are not peer services were incorporated into the exam. And Larry, see you have your hand up.
And so the things that they're doing, you say it's not peer-oriented services, they're like doing the work that the clinicians would do, like, I guess, kind of like a gopher or a runner or whatever, but given a title as, oh, you're the peer service worker, but they're not providing peer services.
Yes.
And I think I know what you mean by that, because I was with a mental health agency in the FSP program. They helped me to get housing, but then they implemented the peer services component, and they told me, well, this person is your peer service contact worker to contact in the event of whatever it is or whatever that. And so that person was just available when the only contact I had with them is they would call me and say, your doctor's appointment is on this date, or your doctor's appointment is on that date. But there was no sessions with them, no plans of actions or any other involvement other than them being. I had their number to be able to contact them, but that was the extent of it. There was no, I don't know, the training that we get or that we're taught, and the role of the peer service person at that time wasn't the same thing, just like you said. They just was pretty much calling me to let me know when my doctor wanted to see me, or I would call them and then they would get in touch with the doctor for me, little stuff like that.
That's exactly what we're talking about.
It's almost as if they're using that title and employing people, but not really putting them in a active peer role, because it would take away a lot of what they're doing. So I guess they don't want to lose that job security or something, but have the peer advocate, have the peer support title or role and position to say, look, see, we are trying to employ peers in a way that they could be useful and supportive to others from their peer group, but really that's not the case. That's all I wanted to say.
Well, thanks for saying it. And I want to say, Sergio, I just emailed you. I also put the PowerPoint in the chat so people can download it if you want. And we'll go with Larry, and then I think is that Sergio? I think so, or S. Gutierrez. Go ahead, Larry.
You have to unmute yourself, Larry. Larry.
Oh, thank you.
Thank you.
Yeah, I hate to tell you this, Jason. I think it's actually worse than you think, because probably the clinicians that you've had contact with at least know what a peer does. Okay. When I did my 5-year plan, for success in Libby's class, taking Libby's class, I was like, wow, this is great. Boy, the clinical world really needs this stuff because it's all authoritarian and, oh, geez, I'm going to take this into the clinical world. Okay. I've talked to clinicians. They have no idea what I do. All right. And worse than that, more often than not, they're really condescending, and they're like, because I'm an unlicensed person. Oh, isn't that nice? You're going to help people. Ah, and why don't you go work for some, peer-run nonprofit? Yeah, but we don't know anything about that. Yeah, the clinical world, so I abandoned my plans to take this into the clinical world. I'm going to keep it in the peer world.
Duly noted. Thanks for sharing. Okay, I think S. Gutierrez.
Hi. Thank you for sharing that information with me. When you send the information, I wanted the PowerPoints on my email. I appreciate it. I just have one question or one situation that I wanted to address. I feel that that the wage disparities with peer support specialists, it's real bad. I think there is a problem.
Can anybody hear me? What's going on?
Somebody else is sharing, Larry.
You can hear me?
Yeah, I can hear you.
Okay.
Yeah, we can hear you.
So I think that I just wanted, the reason I want to say this across the board is because I think earlier I've been on the training since 9 o'clock in the morning. So I went through different topics, different trainings and different presentations. And I heard a lot of people were saying that, they're paraprofessionals. And I want to say that you're a professional. You're not a paraprofessional. As a certified medical peer support specialist, that's an actual, that's a professional title. It expires in 2 years. It could be reprimanded. It could be you can have your certification / license. You can have it revoked. You can have it suspended. You can have people put things or make complaints against your certification or your license. It cannot be renewed until you fix those things or those discrepancies. So you're a professional. You're in the professional world as a clinician, but it's in a peer perspective role, not in a clinical perspective role. And what I was talking about was the wage disparities. The wage disparities are really bad for peer specialists because we're professionals. And I noticed that a lot of peers, we hold multiple jobs to supplement our salaries, and having many jobs, it contributes to burnout. So I'm urging and advocating for honest, decent wages for peer support specialists. We do a lot of work. That lived experience, it cannot be taught in school or any university. And it's something very powerful and something very unique that we all share. And that's all.
Thank you very much. I really appreciate that.
Excuse me, but my audio just went out as I was babbling. Was there any reaction to what,
Yeah, I wanted to piggyback off of what you said, and that's kind of what I was alluding to, and you said it perfectly, because I've noticed that when I've done an internship, and as a peer worker doing an internship, you kind of get the cold shoulder, and they do that condescending thing, just like you said. But when they see that you really know stuff and that you can directly relatable to the clients or the consumers, they feel threatened.
no.
And then they stop allowing me to have any real direct counseling or case management or anything, and they had me just answering phones and stuff.
Wow.
Yeah, that's why I started asking those questions, because I had some similar experiences.
Yeah, the worst part was they had no idea what I do. I mean, yeah. And they were condescending, you know, and so, yeah, that was very, so yeah, I just abandoned the idea of forget the clinical world. I'm staying in the peer world, you know.
Yeah.
Never felt threatened by it.
Thank you both.
I'm
So,
glad you
so Jason,
shared that. Might
I
keep going
guess,
in, but I'm glad you shared that.
yeah, I want to thank Donze, Larry, and S. Gutierrez for sharing your perspectives on the need to give more respect to the peer role in our systems. I think that's very true. Jason, I'm just wondering what some of our next steps might be in terms of providing advocacy opportunities for us to work together to have a voice. Do you have specific ideas about how we can advocate for?
I do, yeah, and I do want to. I saw in the chat, Vic W posted that they are a former resident of California, and they mentioned the SAMHSA National Model Standards, which was released, and that is a good tool. Like Vic said, it's not perfect, and one of the things that it does do is it recommends that training and certification of peer specialists include the ability to connect people to self-help support groups and things like that. So I think that's important. In terms of next steps, I don't know how to do this technically, Libby, but what I'd like to do is is collect people's contact information who are interested in being part of this forum that CAMHPRO and SHARE are going to host in the next couple weeks. And I can get if I get a contact information, I can do a doodle poll for people, and we can find a date that most people are available to, take in this information and then bring it to the table in terms of what it looks like and what we need to do. Like, for one thing we've been doing is Cal Voices is trying to create some legislation to make sure that peer services are mandated across California rather than just an opt-in by counties. Something SHARE's working on is some legislation at the state level so that recovery residences for people experiencing homelessness and mental health are part of the MHSA housing plan moving forward, so that it's not just these really expensive, single room occupancy things. It's places where people experience community and meaning and purpose. So having said that, what's the best way you think to get people's contact information who are interested in being part of this forum?
So all of you are registered, which means we have at least an email and possibly a phone number. If you would like to be part of this forum that is looking at how to advocate for policy change, for legislation, for more support for peer services in California, if you want to just put your name in the chat. George Brott asks, does California have recovery community organizations / centers? It does indeed have many different kinds of recovery centers that range from clubhouse and drop-in center type formats to crisis residential, peer respites. There's a whole range.
And there's also, I would also say, if you're specifically referring to the SAMHSA recovery, I forgot what the title was, but SAMHSA funds recovery organizations, or has a standard for what a recovery community organization is, and California does have some.
So please, if you're interested, please put your name in the chat, and we'll try to capture that and contact you about this upcoming forum. So I see Bianca Dixon, S. Gutierrez, Chris Fessler,
And I
Don't
also
say.
see, I think, is it Jean or Jean has their hand up?
You know, I'm coming late to the game. I somehow got onto the wrong website, but I just want to make a comment that may be helpful and may not. I'm an RN, and only for about 45 years. But the thing is that we were taught one thing in nursing school. Our licensure when I took it was, I thought, was pretty applicable. But then, however, depending on where you went to work, they had a whole nother set of what they expected. And also because of the lack of RN, sometimes the LVN job description, they would stretch it. So I'm just thinking that this peer support, I'm not sure how new it is, but you might be going through that same kind of thing. The licensure exam now, I think, is quite different, but these kinds of things will happen with professionals, like the gentleman was saying. We are a professional. That took a long time. There's a lot of definitions for what we would call a professional. So I guess I'm just trying to be a sort of a cheerleader and say that these things happen, and as a peer support specialist, one might find that when they go to this particular facility to work, you're going to be defined a different way. And it's up to that facility to teach you a whole new set. And then if now nurses have more of an independent practice, neener. Doctors don't like that, but we do. And so I encourage people to look at that independent practice also. I think that's what Larry was getting at, counseling and different things like that. Anyway, 2 cents.
Great comments. Thank you. And you're absolutely right. And I think we're at the place where we're anticipating those issues coming up, because we're at the starting line of implementation for this. And we know that these issues are going to come up. And we're trying to,
and like you said, Jason, you can be the former of that. You can.
That's right. If we do it right. So let's plan for that. All right. I want to thank everybody here. Current jobs, yes. Okay. Thank you all for your contact information. And I'm happy to field questions. I'm also happy to have people leave with an extra 40 minutes in their day, whatever people want to do.
Is there any final comments about conference sessions or things that you want to add in terms of things that you learned about today? Things that we can keep in mind as we plan future conferences and such? Chris?
Yeah, I just want to comment on one topic that I know came up a couple of times, and that is, personally, I have a really strong interest in having more peer services. I know earlier it was defined as like forensic peer services. But my overall thing is, I think it would be very beneficial to our peers, as like substance abuse and mental health and incarceration all and oftentimes overlap. So I think an area that we should all be looking at trying to bridge, like very much looking into, is getting peer services here in California behind bars, where we can go do workshops or sessions with people before they get out, and then find a way of smoothly transitioning where those peers that we make connections with before they're out are able to come to organizations like SHARE, or out in Orange County, the one I work for, Purpose of Recovery. Yeah, I think that needs to be a priority.
Well said. Thank you very much, Chris. Dino.
Hello, Mr. Jason Robinson. Hi, Libby. Hi, everyone else. Thank you for having this wonderful meeting, and thank you for all the coordination behind the scenes. I know it takes an army to get things like this, and y'all make it look really effortless. I did have a thought in mind when Libby just asked about, what could we possibly do in the future, during these meetings. And I've noticed from time to time that when I come back to these wonderful type of meetings or peer conferences, I see a lot of my fellow peers, and that's exciting. And I see a lot of peers in the titles of the attendees, but rarely, and this is not to knock anyone, but do I see administrators from some of these peer respites or these CRTs, or maybe the presidents of those organizations. So I do understand, someone else mentioned it earlier, that there is still this idea that, like, oh, you're a peer, haha, let's go to a clinician for real advice. But it's interesting, to say the least, if we would get some of those administrators on board in these meetings and really, stretch out a warm invite. It could go straight to the source for understanding what we need and what needs to possibly be utilized moving forward. And we won't worry about what happened in the past. We'll just go forward with this approach that the peers need to stick to peer stuff. And this is the why. Thank you.
Thank you, Dino. I appreciate that. And I am all ears if we can get some of our behavioral health leadership at this conference. I would love to have them. And I'm going to take that to heart as we go forward, trying to do some outreach. And I'm going to mention that people at the conference specifically asked that leadership be here, and let's see if we can get them here. I think it might be a little bit easier for the supervision thing. I mean, we've got Jason here. There definitely some of the peer leadership is here.
I think that's a really important part. And, one of the things that we do in our organization, and I know other organizations do, is, we minimize authority. So yeah, I'm an executive level person that works for a peer-run organization. I disclose as a person with lived experience and as a peer, not as like that executive level thing, based on the orientation of this conference. Having said that, I think it's really important that we have some themes in these conferences, and perhaps the next time that we do it, we can look at presentations that talk about administrating peer services, running a peer-run organization.
That's a good idea.
Those kind of things, I'm sure we can get lots of presentations about that will help inform not only all the peer-run organizations, it will also inform the workforce of the kinds of things that come up to keep peer services afloat. So thank you.
It's a great idea, Jason. I know that Gwen Schrank's presentation touched on that. This presentation touches on it. So there were presentations today that were given by leadership in our community, but you're right in the sense that some of the, I don't see any directors of county behavioral health services here. And certainly they can watch the videos maybe on their own time, but it would be nice to have that voice and that presence as a witness to what people are talking about in the peer world, because there's some very important conversations happening here. Sergio notes in the chat, a peer-driven panel might be a good idea next time. It's a good idea too. Other thoughts, feedback?
Maybe there ought to be a national, federal, like, endorsed. Maybe the president ought to initiate an act or put some bill or something together to recognize this peer support specialist, put together some federal something to make it where people accept it, don't take it as a joke, and allow it to, like Chris said, to be implemented in the prison population. I think they do have something like that where peers go in and I don't know, I guess they sit on panels. I don't know if what kind of work they do, but I heard of something like that, what Chris had mentioned. I think they do that in California.
Well, you might be glad to know that Biden talked about the need for strengthening peer support in his State of the Union address in 2022. Right. It is on the radar of the current president. And because of that, we now have these SAMHSA national model standards for peer support certification. So I'm going to post this in the chat in case any of you are interested in seeing what the current administration is thinking about and what SAMHSA is doing. It's not specific to California, but it's still important that that's going on. So it's a very good point. And thank you, Donze, for mentioning that. We need federal support too. Andrew said, thank you for the opportunity to present Census Bureau tools and data. Any nonprofits who apply to federal or philanthropic grants, feel free to reach out for a data workshop to inform your work. Andrew, thank you so much for coming. I'm sorry that I couldn't attend your workshop. I'm going to watch it on the video. Y'all, if you are writing grants, the Census Bureau is ground zero for all data, and they have all of these workshops that can help us learn how to use it. So don't be intimidated. You don't have to be a statistician to be able to put some real numbers in your grant proposals that help show what we're up against and what our communities need. There's a lot of data there.
I will say I was there. I really loved that. Thank you, Andrew. I'll also say, I didn't mention that in this presentation, but we use census data all the time from that website to help make the case for using single-family homes in the solution to homelessness, because with market research and census data, we can look at the number of single-family homes that are available, and that capacity is much greater than apartments or multi-unit buildings in Los Angeles. So, we've got capacity to house a lot of people if we use single-family homes and recovery residences, and we get that data from census. So thank you.
All right, folks, 6 o'clock. I want to bring us to a close and thank all of you for just being here, for presenting, for being a witness, for asking questions, for participating. I'm sure that we'll meet again in one of the peer forums that's being offered. If you've put your name in the chat, you'll be hearing from us regarding the upcoming forum with CAMHPRO and SHARE. And I hope you have a great evening, and that later on you can check out some of the recordings of any sessions that you may have missed. We hope to have those up by the end of February, maybe even sooner. So you'll probably be hearing from us. And again, mark your calendar, April 17th, Peer Supervision Conference. So
thanks, everybody. I'll see you at the forum at the Peer Supervision Conference.
Thank you.
Thank you all so much. We'll see you soon. Take good care, Libby. It's great to see you.
You too, Carolyn.
Good night, everyone. Thank you for all your hard work.
Thank you, Libby and Jason. Really appreciate it.
Yeah, thanks so much, Jason. Good night, y'all.
Good night, Carolyn.
Good night. Good night, everyone. Have a great night.
So long. Bye, Diane.